All right. Welcome, everyone, to the WellMed Charitable Foundation Caregiver Teleconnection with a special presentation today by Dr. Nestor Praderio, who is one of the few geriatric psychiatrists that we have in the United States. There are so few. Dr. Praderio, I looked it up this morning, and it says that there are about 80 people per year that are, actually becoming specialized in geriatric psychiatry. And I'm thinking that's never, ever, ever going to meet the demand with the growth in the older population. So we're so proud and so happy to have you with us. And I would love for you to tell people a little bit about yourself and start your presentation.
Thank you very much, Evelyn. Happy to be here. Well, you go to medical school, then you practice in your residency according what specialty you select. And after you become a psychiatrist, then you do a fellowship, a follow-up, and become a geriatric psychiatry as a super specialty. And with dedication with cognitive dysfunctions, dementia, and pathology of elder life. We were talking about this entity of late life depression because it's honestly a major public health problem. We know very well in our country that depression is underdiagnosed and undertreated. It appeared on the last 7 to 10 years. We probably improved with the attempt to diagnosis. We appear to be a little more awake in trying to collect symptoms and create a diagnosis, but continue is underdiagnosis and poorly treated because sometimes they initiate antidepressant therapy. These are not on the appropriate dose and it's problematic. Second is the elderly population is growing, and this entity of late life depression is growing comparable with their development. And always come hands on hands with medical problems. Therefore, with all of this point in mind, it's very important to take into consideration this is a disorder that occur frequently, this occur on the elderly frequently. This is comorbid with diabetes, hypertension, obesity, alcoholism, and dementia. And there has been, in general, underdiagnosis and undertreatment. A little of what we know about the epidemiology of the disease. The incidence that represent the new cases that we see for years is approximately 1 case in 100 for men and 3 cases in 100 for women. Therefore, the incidence is 1-3 male-female. The prevalence, these are cases that already exist. They are about 2 or 3 for 100 in men and 5 to 10 in women, and 9 to 24% in nursing home residents. Therefore, let's start getting a picture of this. A process of depression is 3 times higher in female than in male. In a process of those cases that are already out there, there is about 3 to 10 cases between men and female. And about 1/4 of people that you go walk in a nursing home is going to have an associated symptoms of depression. And then we need to be careful, because do you have a depression because it's an existing disease that you carry through the years? Or you have a depression that is concomitant with your dementia process? We will talk a little about this, but depressed is depressed. Sex is 2 to 1 women to men. It's almost 3 to 1. Social culture increased risk with family of alcohol and early trauma. Those families, specifically alcoholic, create descendants with a lot of probability to develop depression. It's approximately 1% of 1/4, 25% as a first degree relative. Well, in order for us to have a more simple form to remember symptoms, to put it a little more organized, I choose to divide this in 5 different packages, because we will talk a little about symptoms around mood, symptoms around behavior, around physical signs and symptoms, about cyclic function, and about ideational disturbance. For each one of them, we will go over and getting a better impression in what direction we are moving. The mood-related symptoms commonly occur in elderly becoming very anxious, worry. They ruminate, meaning repetitive thinking about the same subject. And 10 minutes later, bringing up the subject again. A level of worry that sometimes, if you are not attentive, present almost like a panic disorder. Present like for sure, doctor, I never have panic disorder, but now I just don't go on the highway anymore with my car, because I am scared all over, and just I have to go through the city, and I am very fearful. And there are sadness, a sad expression, a sad voice. Sometimes they present here to talk to me with tearfulness, and they have a very much disconnection with present event. We were talking a few days ago with one of a patient that showed up with remarkable depression, and I was teaching the residents, and we noticed immediately that she was disconnected with the present event of life. That she was totally disconnected. The only thing that she talked for a little while is this: we have such a hot summer and it's not raining for months. And she talked a little, but the rest, nothing at all. And easily annoyed, very, very easily annoyed, short-tempered. And that's happened frequently with individuals that have the mood-related symptom. How about the behavioral disturbance? Symptoms of behavioral disturbance is a little of the opposite, is more agitated, restless, hair pulling, hand wringing, might be with retardation or hyperactivity, may come together with a slow speech, a lack of physical complaint, a loss of interest. This is called an anhedonic presentation. And how you pick around this symptom, how you make your family, the person that you care for, or if you're a professional, how you pick a little their brain to know more about what is disturbing. And when we explore anhedonia, is lack of interest in previously enjoyable activities. I always share an example of a patient that I have a close town from here in Corpus, in Kingsville. The patient met me because she wasn't feeling good, because she was feeling sad during the day, and she started doing less activities. She didn't want to go out with friends. She was on the late 60s. And we said and we talked, and I diagnosed her with a late life depression. We initiate treatment. And the next visit, she came with her daughter, that she wanted to introduce her daughter to me. And what I picked from the daughter just by asking questions, something interesting. The daughter said that 3 days before, she went to visit the mother in Kingsville and called her attention that her mother have on the front porch 7 newspapers that she never picked up. Therefore, this is a definition of lacking interest in previous enjoyable activity, because she was devouring the newspaper before. And now she didn't even open the door and went outside to pick up the newspaper. And we need to be careful about those, because sometimes are difficult symptoms to take out. Well, let's talk a little about what they say physically. Well, appetite loss is something very common. They don't know how to define it. They are very difficult to convince. You make comments about how we can improve it. I pick about asking, do you feel any different taste in the food? Is not pleasurable? No, I just eat less. I am not hungry, and blah, blah. But they trying to brush it away. They have significant weight loss. At the point is when I visit nursing home resident, we have a rule, and the rule of my team is any weight loss greater than 5 pounds a month is a matter of attention that we need to discuss with the patient, but with the clinical team too. We want to hear why the patient is losing weight, what are the circumstances, what's any specific change. But fatigue is coming together with them. They are not wanting to participate in activity because they feel tired. They don't want to do the activities on the nursing home that were enjoyed before because they feel tired. They just want to take a nap and stay in their room. What are the cyclic functions? Well, in general, there is a diurnal variation. It's difficult for those individuals to initiate the day. Dr. P, I cannot leave the bed until around 8:30. And then I get a cup of coffee. Well, Dr. P, let me just put it very short and clear. I don't get out of my nightgown until 1 or 2 when I put the makeup and do something. Therefore, morning time is the worst. It's the worst for anhedonia. It's the worst because in order to be more traumatic, you wake up early for a day that you don't want to start. There are difficulty falling asleep, and there are multiple awakening during the sleeping time. But specifically, like I said before, they awake 4:30, 5 o'clock in the morning, but the morning is very heavy for them. That is something cyclic to remember we need to have into consideration. And we finish with symptoms that are associated with an ideational disturbance. And the most common one is the frequency for individual to feel suicidality, a feeling of no worth living, and they don't tell you the majority of the time. This is an issue in which one we need to be careful because you need to obtain this information. There are good studies in the United States showing the individuals that commit suicide they were not lost and isolated on the jungle for the last 5 years. The majority of individuals that commit suicide visit a physician 2 to 3 weeks prior of their killing. Therefore, this is not a symptom that, well, with some exception, but this is not a symptom that just flow out of you. This is a symptom that we need to manage with in a very careful and empathic way. You cannot go and corner someone and ask him, do you feel like you want to kill yourself? We need to be more soft, and we need to take the conversation into point of self-esteem. How are you feeling? Sometimes the patients choose to talk about incommodities with what they own. Sometimes they choose about what they need to continue living in, what they know, pay attention. They open conversation about, well, regardless this, I have the dog for 7 years. Now I think I reach a point, I don't want to be supervising him. I am just looking for someone, good people who will take my dog. You say, well, all of those things are something that you perceptually take into consideration. Poor self-esteem, they are self-blame. In general, when this depression comes together with dementia, when there were movements from their home to live with a daughter or with a son, with the daughter came to live with them to offer more care and supervision. That is a very, very horrible time for self-blame. There are just a self-depreciation and failure. They are bothersome to the rest of the family. Nobody wants to pay attention. Therefore, in this level of decline, we need to pay attention because they are very depressed. A very pessimist I have friends that are pessimists and I pick on them, but this is a pessimism in anticipation that everything is going to be horrible, horrible. And you know that there is no way to demonstrate it. And specifically in the relationship with the professional, with the doctor, the pessimistic attitude is like, why you say I am depressed? And then is why you believe that this medication is going to help me? And how long you think it will take to help me? And those are some of the pessimistic approach. When the case of the depression augment and is very, very powerful, delusions appear. And the delusions are defined as a delusion of poverty. Poverty means such a decline in the esteem of who you are. These are delusions. Your limbs are rotting, that your skin is full of acne, that you are losing your hair, all poorness and poverty. We need to do differential diagnosis. You know, these are depression that are associated with endocrine situation. The most common one is depression associated with thyroid dysfunction, depression associated with cortisol dysfunction. Pain-related is a chronic depression. If we don't treat the pain, we are not going to be able. Vascular depression is post-stroke. Individuals becoming a high percent depressed, as well as mild cognitive impairment in dementia. Cornell University have good work, almost trying to define who comes first, the chicken or the egg, and reporting this, they discover individuals with late life depression, and approximately in a year and a half later, they appear with mild cognitive impairment on the way to have a dementia a year later. Therefore, a little just to salt and pepper our brain and have some idea of this. Is this depression of late life a pre-dementia symptoms? Is this form of mood disorder a precursor of a cognitive disorder? We don't have the real answer. But what we know for sure, and I share with my resident, is if you have depression, you treat it. You don't let it just go, because those ones who receive treatment have better outcome. What I use for tool, I use the geriatric depression scale. It's approximately 15 questions, very easy to answer yes or no. And in adult life, I use Hamilton. I use Cornell scale for depression, and I like it too. Why are comorbid conditions? Mean the depression is together with dementia, with stroke, with Parkinson's disease, very attached to Parkinson's disease. Remember, Parkinson's disease have 3 psychiatric complications. And this goes for Diane too, that she give us a little introduction. She have a Parkinson's disease family member. And the 3 psychiatric disorders associated with Parkinson are depression, psychosis, and dementia. And they go in this way. The first one in appear is depression. Second one is psychosis with some visual hallucinations, agitation, and remarkable paranoia. Sometimes the psychosis is being provoked because between psychiatry and neurology, we need to reach a good balance, not to over-medicate the patient with anti-Parkinson medication because make them psychotic. And for me, not to use too many antipsychotic because make the patient rigid and dysfunctional. But those are the three psychiatric disorders. Depression and diabetes is very common in cancer, in heart disease. A high percent of post-CABG people with operation of the heart end up with an associated depression and a syndrome of late life. What is the syndrome of late life? Start having some cognitive impairment. They have an increased number of falls. They start becoming incontinent, have wobbling gait disturbance, and frailty. Yes, that is the definition of a late life depression syndrome. Well, very good until here. Consequence and disability. We talk and talk and talk and talk, and we are going to say now why this is so important. Well, listen, the first thing is that we're trying to diagnose and treat it to improve the quality of life. Please, if we are moving with individuals pre-dementia or partially demented with no cure, please dedicate some time for what is correctable in those lives. And if they are depressed, treat the depression, please. They will have a better outcome. Be careful with the rate of suicide. This is higher in individuals 65 and older than in young adults. Depression is so debilitating, they impair ability to perform appropriately. An individual that has mild dementia and has been placed in physical therapy to improve mobility have better outcome if you treat the associated depression than the one that you don't treat. And worsening the course of medical illness. There are nice papers showing this is more easy to treat a diabetic individual and provide stability when you treat the depression and increase the risk of heart attack and increase mortality. Therefore, all of those are consequences that we want to say, well, what are we going to do? Let's move in. Briefly, not to scare you, we are going to say that we have treatment with medication, pharmacology, treatment with psychotherapy, talking. We have restorative intervention, psychosocial intervention, and don't get scared. Electroconvulsive therapy has been through the year the most beneficial therapy in cases of very, very chronic and difficult depression to treat. Antidepressants have different family. We are not going to go in detail. In general, I start with one of the name SSRI, and might be Solox, Alexa, Proxa. There are new ones. You need to be careful because some of the new ones the insurance company are not going to cover, or the insurance company will say, well, you can use it after you show me that you failed twice with solar. Or you can use it if you show me the product didn't work for 3 months. And therefore, physicians in psychiatry, and we get a little like, wow, and we just abandon those and go to another. But in general, we use the family of the SSRI and the non-SSRI, and have good combination that you always develop based in your patient. It's very, very important that your treatment plan is going to be developed. There is not identical cookie cutter plans are not working in depression. It's a specific plan. It's tailored to the necessity of your patient. And then you can accommodate it. You can add one chapter that says the family, and open the book of the family, how the family will be integrated in all of this therapeutic milieu. What do we do with psychotherapy, with talking therapy? Where there are wonderful reports about the positive result of cognitive behavioral therapy. I love this form of therapy because I dedicate my last 25, 30 years at doing more geriatric service, 60 and older. I love interpersonal therapy because you peacefully take your track. Sometimes cognitive behavioral therapy is very much regimented by insurance too. Interpersonal, sometimes you can move a little looser. Supported therapy is the best that you can have. Starting with a good friend that you can talk to a good therapist. This specifically in individuals with no good cognitive function. You cannot take a mildly demented individual and sit it in CBT, but it's important to be supported. Art and music therapy, very, very important, very important. In general, I do with my patients supported therapy, and I put an addendum in here. I send them with a little homework with some principle of cognitive therapy associated in here. And I said to them, well, every afternoon when you say that you sit outside and you take your doggy outside, take a book. And for years I was passing small books. Take a book and write down what is going on with you, and write it down. And then they come with a book and they will read just one page. Sometimes they will say, I don't remember exactly why I said this, but that's what I wrote that day. And very nice work, very nice. But those are the psychotherapy. Restorative is medical stability, physical and occupational therapy. I pay a lot of attention to those. And you need to be careful. You cannot do physical therapy and occupational therapy if you don't reach a level of medical psychological stability. I pay a lot of attention in my patients on nutrition. And well, I make recommendation. Not always your recommendations fly. And we live conditions in our life. This I say, well, we eat what we can eat. But I cannot go so academically and say the greenish of the veggies are the best for your brain, and go and get asparagus, spinach, and the people look at me and say, lettuce and the cheapest one. Okay, go and get salmon and get tuna. Well, in general, we try to accommodate and passing a message of what is more or less healthy for you. We are going to summarize. I didn't check to Evelyn, but I think I am navigating okay with the time, right, Evelyn?
You have lots of time. You have 20 minutes left.
Oh. But we promise, Evelyn, that people will ask questions and we will participate.
Yes.
Well, we summarize by the late life depression is a lot more common than what we believe. I didn't show up in here today with an entity this from where he came with this. No, it's an emerging understanding in how to diagnose it. It's very comorbid with medical illness. It's very comorbid with dementia and other cognitive impairments, but specifically with Alzheimer's, with vascular dementia, with Parkinson dementia, with trauma dementia, very comorbid. To the point is returning to Parkinson dementia. If it's associated with a depressive component, it's imperative to treat the depression in those Parkinson individuals in order to be successful for them to have a better outcome, a better quality of life. Go and recognize in undertreated, very, very sure. There are two pathways in here because if it's unrecognized, the patients in general, they deny symptoms of depression. To say that you are depressed is stigmatizing in our society. They really tinted dark the name of depression. Historically, this is through the years. People interpret this to be depressed as to be weak. I have a grandpa, Italian grandpa, living in Argentina, and you know this, I finished my residency and I was a surgeon, I was a trauma surgeon. And he was like a punch in the chest, my young kid, I mean, surgeon here and cut and here. And then his grandkid came to USA. And he decided to get off of the horse and to jump into psychiatry. And the first visit that I have with Grandpa, and we would drink mate. This is it's kind of a green tea. And he said to me very clear, like enhancing my change of specialty. He said very clear, their psychiatry is just pure BS. Anything from here, you can drive, you can control it. That was my Italian grandpa. He didn't even believe about psychiatry. But anyway, but this is the unrecognized, carry a package that starts with the patient, then with the family, then with the people that don't want to believe, then for the one who look for excuses, and finally, if a diagnosis takes place, they will have some problem in how it's treated. The treatment takes longer, improve always quality of life, and help very much improve the course of medical illness. I'm going to stop in here, and we are going to accommodate at least 10 good minutes for questions and answer. And please, Evelyn, suggest and recommend to that they can widen the spectrums of question, not necessarily focus on what we talk today. If you have some associated demented issues, ask. I am in here to do my best in answering your question.
And what an invitation.
Mm.
So folks, just press *6 if you're on the phone, press unmute if you're on Zoom. We would love to hear from you, and we have an expert to talk to. Diane?
Oh, okay. Let's see. So my dad is a tough one. So he basically is in a nursing home, memory care. And he has had psychosis in the past and hallucinations, and but he's on medication. He seems very articulate. He is articulate. And so anyway, but he has a back problem he's always had, and with the Parkinson's, so he can't really walk or get up on it. He can walk once he gets up with help, but he's extremely immobile. So he's depressed, and it's like, well, we can't get him to agree to go out on the patio. We can't get him to agree to go on outings. He just wants to stay in his room. So we've suggested psychotherapy, but he's of that generation that just poo-poos that, and also
My grandfather.
right, he's like your grandfather, and so he's just a tough one. Like, he's just staying in his little room and ruminating and this and that, and God knows what's going on. And we can't seem to move the needle on it at all. So I don't know, what would you say to that?
I would say, Diane, 3 different legs. Let's go and settle the table in 3 legs. Number 1, Diane, in those cases, will be important to have some support in attempt to initiate antidepressant therapy if a good diagnosis takes place. I am not just diagnosis by Zoom or throwing medication, but you need to remember this: an antidepressant can make a significant change in his mood stability. They are difficult to treat, Diana. And in general, there are some antidepressants that work better than others. But this will be treatment, 1 leg on the table. The second one, Diana, we need to rule out, surely, that he is not in pain. Because, Diana, to have Parkinson can be associated with contractures, with rigidities, with hyperextensions, an incredible amount of distorted muscle structure and pain. And that might be the core of the immobility, and he preferred to be just lying down quiet in bed than to move from here and there because we exacerbate his pain. Very important to know and to work with the pain and to make little tests. Let's go. We will invite him after I give him 2 Tylenol. We have some activities on the patio. Well, at 2 p.m., give him 2 Tylenol. All of this with the doctor supporting. You give the 2 Tylenol, and 1 hour, hour and a half later, we will see what is the response. He probably want to get on the chair. He probably want to move out and do something like that. And third, we need to inject on him some mental activities. And when I say mental activities, if you cannot take Because you can take your daddy Diana to the little patio and he will be with the eyes closed, not talking to anyone. And therefore the intent won't be very positive. But I think a little he will like to have earphone, or if no, you can get some book on tapes, or you can get some pod for him to be listening, because I want him increasing. You say that he is having his brain and he's articulated about him having a conversation going to him and making him to think.
So what kinds of books would you say?
Name? Well, name in general, we are successful with duloxetine, and we are successful. Duloxetine is called on the market Cymbalta. And we are successful with bupropion, it's called Wellbutrin. But Diana, I am not passing medication.
Oh, I know.
I am just giving them.
Yeah.
And when you visit, if you visit, Diane, we will put you in charge on important intervention. Let's say that you visit him 3 times a week. Well, do a little the talking of daughter, hey, yeah, and then involve in some reminiscence. Sit down by him and start talking about 10 years ago, 10 to 15 years ago. And you will notice this is not common that I come to visit you to talk about my graduation. But no, do some reminiscence because it's very important to wake them up. Okay.
Great, thank you.
Your question
Great.
is very good.
Yeah, great question. Let's have some more. Just press *6 if you're on the phone, or unmute yourself. If you are on Zoom, we love the questions. We makes our podcast so much richer when we hear from you folks.
Evelyn, I have a question in front of me and here from the chat. And the question is, how can you diagnose depression on a patient with advanced dementia, especially if they are not able to, if for sure say they are not able to communicate? Excellent question. Excellent question. How we can diagnose in an advanced stage of dementia? Very difficult. Remember the 4 or 5 different forms that I present the symptoms? You need to look at facial expression. You need to look at mobility. You need to look at comorbidity with other medical illness and comorbidity with dementia. And you need to hear this in an advanced dementia, there is a high percent, higher than 25% of the individuals that are going to be depressed. Therefore, if I am the treater, I will do my best to initiate very slowly treatment with an antidepressant medication. Very, very slowly, I will initiate the treatment. And that's it. And that was the answer for the person who asked on the chat. Question, more questions.
Yes, please. Come on, folks. We need you here with us. I wanted to just make a little comment, if you don't mind, Dr. Praderio, when you gave the statistics about men versus women and the level of depression. I've read studies that say that men just don't report it, that it's very underreported. And I think that's supported by the fact that men have the higher suicide rate among older adults.
You're right. Excellent point, Evelyn. Excellent point. And besides, you just offered the tip of the iceberg. because you are right. The formation, cultural component of the man is not reported. Not reported. It's not hurting. I am okay. Yeah. But Evelyn, there are others. There are Scandinavian studies. There are some European studies in which one, how we educate our kids impose in some of this prevalence of dementia and the sexual difference. Specifically, historically, giving a woman a role, this is always less important. And by the way, Evelyn, a lot of trauma occur with women nowadays. And it's very impacting because that's at the core of many depressions. I enjoy being with all of you. Evelyn, check with Marianne. She may have some info for us. And thank you very much. One more time, Evelyn, thank you for participating. And thank you all of you for coming today.
Dr. Praderio, I always learned so much from you. Thank you so much.
Thank you very much.
Is Marianne going to come on now?
I hope.
Hi, Evelyn.
Hello there.
Hi. Okay. Thank you, Dr. Praderio, for a wonderful presentation. And we just wanted to let you all know that we will be holding our annual Walk for Memory on November the 5th. It's going to be at Water's Edge Park here in Corpus Christi, and it will be hybrid, so you can join us virtually if you would like. At least 90% of the funding goes to respite services. So please come join us. It's a lot of fun. We plan even to have a bigger walk this year. So please join us. Even if it's virtually, we'd love to have you all. And for a phone number, if you have any other questions for Dr. Praderio, you can call 361-826-2343. And I can take any messages down for him, or you can visit face-to-face on Facebook, Texas Face-to-Face, or on the website. It's going to be texasfacetoface.com.
Fabulous.
So that's all we have.
Thank you, Marianne. I'm just going to do a few wrap-up things here.
Okay.
For those of you who are still on with us, just want you to know that we'll be sending out a couple of resources for folks for depression and dementia with the post-session questionnaire. We would really love for all of you to have those and to fill out the questionnaire for us so we can improve what we're doing. But I also want you to know that if you just got this phone number from somebody else, or you got on the Zoom call from somebody else, that you won't get those. So please call our customer service representative at 866-390-6491 and get registered. And when you get registered, you not only get those resources and our post-session questionnaire, but you're going to get this great calendar that goes out every month with all of the new presentations that we're going to have, all experts, all topics related to caregivers, caregiver professionals, and family caregivers. And we would love for you to join us and be part of our caregiver teleconnection community. So let me tell you about a couple of them. Tomorrow, we're having one by Dr. Sklar and Lucy Barilla that's about difficult situations in elder abuse. And it's particularly going to be set for professionals. So it will be very interesting in the sense of, we don't always recognize, we don't always sense what's going on with people. And they're going to give us a lot of information on how to do that. They also have another one on the 17th on diversity and caregiving. In addition to that, we've got, oh my goodness, dear Lucy's going to do how music can help people with dementia, speaking of music therapy. And that's on the 11th. On the 25th, we have high conflict relationships and its impact on you as a caregiver. And for those of you who have family that don't agree with the way you do caregiving, or you don't agree with the way they do caregiving, this should be a very interesting one for you. On Friday, the 26th, there's going to be a Spanish presentation, and that will be about food as medicine. and really talking about how food can help deal with chronic illness. On Tuesday, August 30th, that'll be our final one for the month, and that's dementia and the hidden patient. Because as Alzheimer's caregivers, many times feelings go unaddressed. And I think Dr. Praderio covered that one pretty well. So that's what I have to say today, and to say to all of you, thank you so much. Thank you for attending. Thank you for your questions. Thank you for your chats. He is always just, the best provider, best presenter. And I want to thank all of you for what you do. You are the backbone of long-term care in our country. And thank you all for your messages. And if you have questions about some of the future sessions, as we have in the chat room, please call the customer service person. Again, that number is 866-390-6491. And with that, I would like to thank the WellMed Charitable Foundation for supporting all of this caregiver teleconnection, the podcast. They have SOS on air. They have SOS centers. They've done so much for caregivers, and we're so proud to be part of that. And so I say to all of you, goodbye, and thank you so much for joining us today. And please refer people to the podcast. Dr. Praderio's presentation will live on forever. Well, as long as the podcasts. Goodbye now. I'm going to stop the recording, and I thank you all.
Thank you. Bye-bye.